Okay.
You can start, Parthi.
எத்தனை பார்ட்டிசிபென்ட்ஸ் வந்திருக்காங்கன்னு கேக்குறாங்க சார். லைவ் ஸ்டார்ட்
It's
பண்ணாதானே தெரியும்.
YouTube. It's in YouTube, Dana. We can see in YouTube, so you can start.
Okay.
Okay.
Very good
Start
evening. நான் ஒரு இன்ட்ரோடக்ஷன் கொடுத்துறேன் சார்.
Okay. Right.
A very good evening to one and all who have gathered here for this YouTube live. Today we have an ENT series on the topics carcinoma, larynx and tracheostomy. And for this we have our most respected faculty, Dr. Vinothan VR sir, DLO, MS, DNB, ENT. He's a consultant ENT surgeon from Tirunelveli. It's an honor to have you, sir. The session is all yours. You can proceed with the session.
Thank you very much. So let me introduce myself again. I am Dr. Vinothan. I did my UG in Tirunelveli Medical College, 2009 batch. I did my diploma in Madurai Medical College, 16 to 18, and masters in Kilpauk Medical College from 20 to 22. So I've been working as a consultant in various hospitals in Tirunelveli and running my own clinic. So I'm very happy to share this carcinoma larynx and tracheostomy with you students. So we'll go into it. So this carcinoma larynx and tracheostomy is a very important topic for the undergraduates because even essay questions are commonly asked from this. So we will be covering a brief introduction about the anatomy of larynx and then go into carcinoma and then we will go into tracheostomy. So you all know larynx is also called as voice box. So you know that. So the larynx is present in front of the hypopharynx and it is present opposite to the vertebra. Okay, so it extends from epiglottis to lower border of cricoid. Upper border of epiglottis to lower border of cricoid. Okay, so the larynx has cartilages which is unpaired and paired cartilages. So the unpaired cartilages that you know, that is thyroid, epiglottis, and cricoid. So these are the common or major cartilages which are unpaired, that is single in number, and paired cartilages that is very small and there are two in number. So you can remember like mnemonic. So all college cute girls or boys are paired. This is a common mnemonic we use. So that is arytenoid, corniculate, and cuneiform. Sorry, some issue. I think just a minute. Arytenoid, corniculate, and cuneiform. So these are the paired cartilages. So totally there are 9 cartilages. So 3 unpaired and 3 paired, which means that is 6 cartilages. Okay. So the larynx is also called as voice box. So it is most important to maintain or protect the airway, and it helps in respiration, and it also helps in phonation. Okay, so extent it is from epiglottis to lower border of cricoid. Just a minute, I think. Just a minute. Sorry. I think there is some issue in that tab. Okay, we'll continue here. So the larynx is present in front of the hypopharynx and it is present opposite to the vertebra. Okay, so all college cute girls or boys are paired. This is a common mnemonic we use. So that is arytenoid, corniculate, and cuneiform. So I think there is some issue in that tab. Okay, we'll continue here. So extent is from epiglottis to cricoid. So that is at the level, if you say it is opposite to C3, C4, C5, and C6 vertebra against these vertebra. Okay, so it is uh, it is very important for maintaining your airway or protection of airway. It is a primary function of the larynx and respiration, and of course phonation. Okay, so if you see, this is the thyroid cartilage, which is the largest thyroid cartilage. Okay, so it has an angle which is 90-degree in males, so that is called as Adam's apple, and in females it is 120-degree. Okay, so it has an oblique line here, and it also has an articular facet where this is the articular facet where the cricoid. So this is the cricoid cartilage. So the cartilage articulates with the thyroid. So that is called cricothyroid joint. So cricoid cartilage is the only complete ring-like cartilage. Okay. So it is the only cartilage which forms a complete ring. So this is also called the cricoid cartilage is also called as it looks like a signet ring. So and this leaf-like structure. So in the midpoint of the thyroid cartilage, inside the thyroid cartilage, there will be the epiglottis will get attached. Okay. So this is the epiglottis. So it is a leaf-like structure. It's a leaf-like cartilage. Huh? So it is present in the midline. So it is attached to the hyoid. This is the hyoid bone. So you can see this is the hyoid bone. So it is attached to the hyoid using the hyoepiglottic ligament. And in the epiglottis, there are some numerous pores in the midline. So why this is important, because in CA, in carcinoma of epiglottis, through this minute openings, there will be high chances for metastasis. So it will go to opposite side also, opposite side lymph nodes. So these are the three unpaired cartilages, which is most important before going into the carcinoma per se. So this is the another view of the cartilages. So this is the epiglottis, which is, you can see the attached. This is the thyroid cartilage attached in the midpoint or center, and these are the other cartilages or paired cartilages, that is cuneiform. These are the corniculate, and this is the arytenoids. Okay. So, and another brief introduction about the cavity of larynx, which is also called as the inlet. So, in the cut section of the larynx, you can see like this. So, this is the subset, or this is the subdivision where the larynx is divided into supraglottis part, glottis, and subglottis. So, these three are the divisions of the larynx or subsets of the larynx. Okay. So, the supraglottis part is above the glottis. Okay. It includes various parts. We will go into that later. So, cavity larynx per se, it includes the, so here there will be epiglottis like this. So this is the inlet of larynx. So this inlet will also act as a sphincter for larynx. And next is the vestibule, and below the vestibule there is inlet, and then vestibule, and then there is rima vestibuli, and then there is ventricles, which is between the true and false vocal cord, and rima glottitis, which is the true vocal cord, and then subglottis. So the cut section of the larynx shows like this. So up till this ventricle, this is called as supraglottis. Okay, and rima glottitis are the true vocal cord that represents glottis, and then the subglottis. So this is the cavity. So and this is the subsides of supraglottis, glottis, and subglottis. So coming to the subsides of larynx. So supraglottis, that involves epiglottis. So the epiglottis has two surfaces, lingual surface and laryngeal surface. So both the surfaces of the epiglottis are the epiglottic fold. The arytenoids, false vocal cord, and ventricle. Okay, so the supraglottis involves, it includes these five structures. Okay, I'll show you in the laryngoscopy picture. So you should know what is supraglottis. It is a region above the glottis, which includes epiglottis, both the lingual and laryngeal surface. The aryepiglottic fold, that is the fold connecting the arytenoid and epiglottis. Then the arytenoid cartilages, false vocal cord, and ventricle. Then this next one is glottis, which involves the two true vocal cords, and then there is anterior commissure and posterior commissure. The third subsite is subglottis. So when we talking about larynx or carcinoma of larynx, so it includes three areas, that is supraglottis, glottis, and subglottis. So we should be specific about which one is we are talking about. So larynx doesn't mean only glottis, okay? So it includes supraglottis, glottis, and subglottis. Within that, there is divisions. So this is the laryngoscopy picture, or indirect laryngoscopy, or video laryngoscopy, whatever you can say. But this is not direct. I will say the difference, which is what is direct and indirect. So take this as video laryngoscopy. So this is how the larynx looks like. Okay. So you're passing the endoscope. So this is how you do a video laryngoscopy. You make the patient to sit, and you pass a endoscope, possibly 70 or 90 degrees endoscope. A camera is attached, and when you pass beyond the tongue, so this is what you see. So this is the epiglottis. So this is the cuneiform, and this one is the arytenoid. So the thing that is connecting arytenoid and this epiglottis. So this is called as aryepiglottic fold. Okay. So here this is the aryepiglottic fold. This is epiglottis. So here there is before the epiglottis there is vallicula. Just you can't see here now because the epiglottis is covered. And this one is the true vocal cord. and this is the false vocal cord. Okay, so the area in between this, you can see between true vocal cord and false vocal cord, this is called as ventricle. You saw it in the cavity, right? So this is the laryngeal surface of epiglottis, and below this, that is lingual surface of epiglottis. Okay, so the when the two vocal cords meet anteriorly, this portion is anterior commissure. Okay, so I'll show it again. So this is the ideal mirror. So in the OPDs where there is no video or endoscopes available, so we can see use this ideal mirror to look at the uh, larynx. So this is the direct laryngoscope. You can see you would have seen in an operation theater where the anesthetist will intubate. Okay, so here the patient makes the patient lie down, and you pass the laryngoscope directly. So you will see the larynx like this. Okay, could you remember this is so in this the image is inverted. That is indirect. You can even in indirect laryngoscopy you will see the larynx like this. Okay, so you will see the epiglottis below, and you will see the arytenoids like this, and you will see the vocal cord like a V shaped. Okay, if the vocal cord is like V shaped, then it is an ideal type or video laryngoscopy. If you see the vocal cords like this, like A, inverted, and epiglottis above, so it is direct laryngoscope, direct laryngoscopy. So in this, the patient is supine. So when you pass the laryngoscope and lift the tongue above, so you see like this. So this is the epiglottis. This is the true vocal cord. This is the false vocal cord. And this is the ventricle between true and false vocal cord. This ventricle. This is the aryepiglottic fold. And this one here is the pyriform sinus. Okay, so this is the anterior commissure, and this one here is the posterior commissure. So this is the another picture. So this is the indirect laryngoscopic view. Okay, so where you see the vocal cord like V. So the area above this, so this epiglottis, AE, folds, the arytenoids, the false vocal cord. So these constitute the supraglottic portion. Okay, so this vocal cord, anterior commissure and posterior commissure. So this three involves the glottis. Okay, so this arytenoids. This three includes supraglottis. So why we should know all this? Because to differentiate the CA larynx, its anatomy and its where it is. So functions of larynx, as I said, it helps in protection of the airways, respiration, and phonation. Okay, so phonation, it is so that's why it is called as voice box, and it increases the intrathoracic pressure, helps in increasing the intrathoracic pressure, so helps in fixing the chest during any strenuous activities or exercises. So that's why the larynx is important. So if the larynx is removed, in the case of carcinoma of larynx, if the larynx is removed, it is total laryngectomy. So these functions cannot be performed by the person. So and another small differentiation between pediatric larynx and adult larynx. So in infant, the larynx is often funnel shaped. Here it is cylindrical, and the epiglottis is omega shaped. Here it is a leaf-like structure. So the narrowest part of larynx in infant is subglottis, that is below the vocal cord. In adults, it is glottis. Okay. So in infants, the larynx is always high placed. So it is opposite to the extent is between opposite to C2 and C3. In adults, it is as I said C3, C4, C5, and C6. Okay. So this is the common difference between infant and adult larynx. So now coming to the carcinoma larynx. So I think the basic anatomy will help you and understand the main topic better. Okay. So carcinoma of larynx, so the most common malignancy of most common larynx is most common carcinoma of larynx type is squamous cell carcinoma. So it is common in male more than female, and human papillomavirus infection has a predisposition, and any previous irradiation to neck can also lead to carcinoma larynx. Okay, so carcinoma larynx, as I said, there is by the subsides we differentiate. So first we will go with the supraglottic cancer. So you can see here the growth. This is how the cancer will be visualized in indirect laryngoscopy or endoscopic picture. Okay. So this is the epiglottis. See, this is the growth. Okay, or see, and here it involves the ariepiglottic folds. So this is C supraglottis. So in CA larynx, so the most common type or the most common site involved in CA larynx is glottis. So glottis is the most common, followed by supraglottis, and then followed by subglottis. Okay. So glottis is the most common malignancy among the CA larynx. Next is supraglottis. You know the subsides. In supraglottis, there are different subsides. So whichever part, that is, it might be epiglottis or arytenoids or ariepiglottic folds or false vocal cords. So in any of this subside, you can call it a supraglottic malignancy, and subglottis the area below the vocal cord. So this is the supraglottic cancer. And I forgot to mention, as CA larynx, smoking and alcohol plays a major part. So even if it is combined or separate, the person having smoking or alcohol history, you should never miss CA larynx. Okay. So you can see the spread. This is a spread of CA larynx. So the supraglottis is usually rich in lymphatics. Rich in lymphatics. It has a rich lymphatic supply, and glottis has no lymphatic supply. Okay, so glottis is also so in CA glottis or CA vocal cord, there won't be lymph nodes or lymph metastasis. But in supraglottis, it is rich in lymphatic supply, so it often presents with uh, lymphatic or lymph node enlargement. Okay, so the supraglottis most common, the lymphatic supply for supraglottis is level 2, 1, 3. Okay, so this is these when in CA supraglottis, these level 2 and level 3 nodes are the first to get involved, are the most common to get involved, and these two groups will get enlarged. I think levels of lymph nodes we will see. So level 2 means your jugular-digastric nodes or the upper jugular, and level 3 is the middle jugular group. And subglottis, the presentation will be stridor. Okay, so clinical features, as I said, glottis, that is the true vocal cord malignancy, has the best prognosis. Why? Because it presents early. Why? Early presentation in glottic cancer, because voice change, even a slight change of voice, the patient will go to the doctor immediately. Okay, so voice change is the first symptom of CA glottis. So any slight change in the voice, the patient goes to the doctor, and the vocal cord malignancy can be picked up so early. So in the patient presents in the earliest stage, so it can be treated well. So it has the best prognosis. In supraglottis, since it has rich lymph node supply, so lymph node enlargement is the uh, first, in many cases of CA supraglottis, lymph node enlargement is the first symptom or dysphagia. So many dysphagia has been ignored by the patient. So in slightest, even if there is slightest of dysphagia and elderly patients, there should be a suspicion. It can be a malignancy. Okay, and there can be referred autolgia because the epiglottis, the base of tongue, all these areas there is vagus nerve supply, which also supplies ear. Okay, so when these areas get involved, there might be referred autolgia. So these are the common presentations of supraglottis, and subglottis usually presents with stridor. So that is below the vocal cord. And in the spread, where the carcinoma can spread is first is pre-epiglottic space. So it can spread to adjoint areas. So the most important thing is pre-epiglottic space. It is also called as Tucker space. Okay, so it is the site for spread This is the pre-epiglottic space. Okay, so it is bounded. You can see. So this is the epiglottis. This is the hyoid. So anteriorly, so this is the pre-epiglottic space. Anteriorly, hyoid. So and in between hyoid and thyroid, there is thyrohyoid membrane. And this one is the thyroid cartilage. Okay. So posteriorly, you can see the below the hyoid. So this is the infrahyoid epiglottis. And superiorly, the hyoid and epiglottis is attached by hyoepiglottic ligament. So this is a space for spread of the CA supraglottis or CA glottis. So it contains none other than vessels and lymphatics. So okay, so there is a pre-epiglottic space. So site for spread of malignancies. Sorry, this is pre-epiglottic space, also called as, sorry, the other name for pre-epiglottic space is Boyer. The other name of paraglottic space is Tucker. So it is also used for tumor to spread. So this is the paraglottic space. Okay, so that is present side lateral to the glottis. So this is the vocal fold. This is the glottis. Okay, so this is the paraglottic space. So it is this is the thyroid cartilage. So you can see laterally thyroid. Medially there is this is called ventricle. So there is ventricle quadrangular membrane, and anteriorly, so in front of this, that it communicates with the pre-epiglottic space. And posterior to this, there is pyriform fossa. Okay, so the both the spaces, pre-epiglottic space or a space of Boyer and paraglottic space, the both the spaces, it has same contents. It is fat and vessels and lymphatics. So when these spaces get involved, it goes to the nearby, the adjacent structures. Okay. So next is when the adjacent structures are involved, it goes to lymph nodes also. So lymph nodes, as I said, the supraglottis, it includes level 2 nodes, level 3. So level 2 is jugulodigastric or upper deep cervical. Level 3 is middle deep cervical. Glottis, as I said, there is no lymph nodes, and subglottis, it involves the anterior group. Anterior, that is level 6. And the pretracheal, precricoid nodes, lymph nodes. Okay. So you can see the levels of lymph nodes. So level 1, which is the submental. So level 1 includes 1A and 1B. So I think there will be more vast to you. But for your level, you just know the levels of lymph nodes and the name. So submental. Level 2 is jugulo-digastric or upper deep cervical. So level 3 is middle deep cervical. Level 4 is lower deep cervical. Level 5, it includes the nodes of the posterior triangle. Level 6, here, anterior triangle nodes or midline. And level 7 is the mediastinal nodes. So for CA larynx, this level 2, level 3, and level 4 sometimes, but 2 and 3 are the most common. Okay. And for subglottis, level 6 is most common involvement. So you can see the patient presenting with just only lymph node involvement in the supraglottic cancer. Okay. So this is level 2. Jugulo-digastric nodes getting involved. So coming to TNM staging of CA larynx. So T involves tumor size, N lymph nodes, and M for mets or metastasis. Okay. So it is important for you to know the tumor staging. Why? For deciding the treatment protocol or the treatment perspective. Okay. So in TNM staging, T. So T0, there is no tumor. So then is T1. Okay. The tumor is confined to, I'm writing this TNM staging common for CA larynx, and then I will differentiate it from all the three subsites. Okay. So T1, tumor is confined to one subsite or site. So if in supraglottis, either epiglottis alone or arytenoid or only AE fold or false vocal cord. Okay. So that is one. So it involves only one subsite. If it is glottis, that's T1A and T1B. In T1A, it involves only one vocal cord. So it may be right or left. In T1B, it involves both the vocal cord. Okay. So T2. Okay. T2 means it involves the tumor, it involves two subsites or the adjacent sites. So it might be epiglottis plus arytenoid or AE folds like that. So this is for supraglottis. So in glottis, it involves both the vocal cord, with mobile vocal cord. The vocal cord will be mobile, and in T2B, with some impaired mobility, but it is mobile but not completely immobile. Okay. So T3 is common for everything, for every malignancies. There will be whichever subsite, even if it is one subsite, there will be vocal cord fixation. It may be supraglottis or glottis or subglottis, whatever. So vocal cord fixation, how? When the tumor spreads to pre-epiglottic or paraglottic space. Okay. So T4, when the tumor is spreading outside the larynx. So T4A, it involves uh, cartilages, that is thyroid cartilages outside the larynx, thyroid cartilage, gland, the strap muscles, esophagus, and T4B, it is an inoperable tumor. We call it as inoperable tumor, where it is more extensive that the tumor spreads into prevertebral fascia, carotid sheath, and mediastinum. So if it is T4B, we call it as inoperable because the tumor goes beyond the surgical margins of resection. Okay. So T1, when the tumor is confined to one subsite or site, so it may be in epiglottis or arytenoid or AE folds in supraglottic cancer, and in glottis it involves T1A and T1A it involves one vocal cord, and T1B it involves both the vocal cords. Okay, so in T2 of supraglottis it involves two adjacent sites, might be epiglottis with arytenoid or AE folds, etc. Glottis T2A means both vocal cord, which is mobile, and T2B there is impaired mobility. T3 there will be fixed vocal cord, and T4 outside the larynx. So T4A cartilages, esophagus, glands, and T4B prevertebral fascia, carotid sheath, and mediastinum. So likewise, lymph nodes. So lymph node staging. So N0, no nodes. So why you should know this thing to for designing the correct treatment for the correct stage. Okay. So N1. So single ipsilateral or the same side node less than lymph node classification is same for all the three cancers. Okay. For obviously for glottis there won't be any lymph node involvement. So for supraglottis, single ipsilateral node less than or equal to 3 centimeter. Okay. N2, so single ipsilateral node with 3 centimeter to 6 centimeter. So N2 it includes 2A, 2B, and 2C. So in 2A there will be one ipsilateral node 3 to 6 centimeter. In 2B, multiple ipsilateral node. So multiple but same side node, which is less than 6 centimeter. And N2C, multiple or single node. It can be in same side or it involves the opposite side, that is contralateral side, opposite side. And the node should be less than 6 centimeter. Okay. So N1, the node should be on the same side, less than 3 centimeter. N2, 3 to 6 centimeter. So N2A, one single node in the same side, 3 to 6 centimeter. 2B means multiple ipsilateral node less than 6 centimeter. In 2C, it might be multiple or single, but if the node goes to opposite side, then it is 2C. Okay. So then N3, it involves lymph nodes more than 6 centimeter. So 3A means one ipsilateral node more than 6 centimeter, and N3B, so any size with extranodal extension. So this can be made out only after biopsy. That is your histopathological examination. Okay. So with this, what do you know? The N1 and up to N3A, there is no extranodal extension. Okay. So if any node of any size, even it may be 1 centimeter or 2 centimeter, but if there is extranodal extension, it automatically comes under N3B. If any node without less than 6 centimeters, but if there is no extranodal extension, then it may be N1 or N2 and N3, depending on the size, you have to categorize. Okay. So coming to the management of CA larynx, you all know first we will go with investigations. So I think you up to this you are clear. So how the malignancy presents and what are the common complaints. So I'll once again go with the clinical features. So for supraglottis, dysphagia or lymph node enlargement, referralgia, and if the malignancy is very bigger in size, it can cause respiratory obstruction also. Glottis, earliest voice change, and if the tumor is big, it can also cause respiratory obstruction. And subglottis, so below the vocal cord there is trachea, and the malignancy goes there. Obviously, stridor, patient presents with stridor. It's very difficult. So this is a common clinical features of the of the CA larynx or the subsides. So you have seen the spread, you have seen the lymph nodes, common lymph nodes, and TNM classification so far. Okay. So now we'll go to management. So investigations. First, we'll go for X-ray, X-ray soft tissue neck to see the vertebra, airway, and any soft tissue shadow there, or any soft tissue present. That may be shadow. So, but X-ray is not conclusive. So next we will go for contrast enhanced CT scan. And sorry, before X-ray and before imaging modality, will go for indirect laryngoscopy. Obviously, there will be physical examination, but that doesn't come under investigation. So indirect laryngoscopy or video laryngoscopy to look for the tumor. And then for imaging modalities, X-ray, contrast enhanced CT, which will give a definite conclusion. And MRI in case of any vessel involvement or any soft tissues. So we can also stage by imaging. Okay. So staging, there is clinical staging, radiological staging, and pathological staging. So clinical staging, how you stage by seeing the patient and clinical examination. And this is with CT and MRI, you will go for radiological staging. And pathological staging after removing the malignancy and sending it for biopsy. Okay. So coming to treatment, you can see this is the CA glottis. What stage this is? It involves only one cord, so possibly T1A. Okay. So the primary aim of treatment of management is because larynx has more function, so we have to preserve the primary function of larynx. So any disease, any management, the main aim should be you should restore the function as much as possible. Okay. So with the staging, so if it is T1, in this you can go for transoral laser microsurgery. So laser we use is CO2, which is most commonly used, or you can go for radiotherapy. Okay. So T1A, if it is in mid vocal cord, if the, for example, say if the tumor is present here, you go for surgical excision. Because in radiotherapy there is numerous side effects or adverse effects are there to adjacent structures. Okay. If the tumor is operable and if it is in the middle of the vocal cord, you can go for surgical excision. If it is both the vocal cords, can go for transoral laser microsurgery. This is rated as TLM, transoral laser microsurgery or radiotherapy. Okay. And in T2B, T2A and T2B, first we'll go T2A and go for radiotherapy, same or transoral laser microsurgery. So only up to T2A, you can go for transoral laser microsurgery, and in T2B, there will be deeper invasion because there will be slight vocal cord immobility. You know, right? So RT, that is radiotherapy, is the only treatment. So this is the transoral laser microsurgery or microlaryngeal surgery. This is the setup of the microlaryngeal surgery. Okay. So in T3, what you give is concurrent chemoradiotherapy. So both chemotherapy and radiotherapy. So the commonest chemotherapy drugs you use is cisplatin, carboplatin, and trifluorouracil. So this is for T3A. T3 means there is focal cord fixity. Okay. So in T4A, where the tumor is within the adjacent structures, you can go for total laryngectomy, followed by radiotherapy. So in T4A, if the cartilage is involved, then you should not give radiotherapy because it can cause pericontitis. Okay. And T4B, where it is inoperable, can go only for palliative therapy. So palliative means for you can symptomatic management for pain or for if there is respiratory difficulty, you can go for tracheostomy, and if there is pain, you can go for painkillers. Okay. So, I don't think your stage is much important for you in your UG standards. So you should know the treatment alone. So summarize. So T1 and T2 up to T2A, you can go for transoral laser microsurgery is one of the option, and radiotherapy. And T2B, you can't go for transoral laser microsurgery, only RT is the treatment. And T3, concurrent chemo RT, both chemotherapy and radiotherapy. So T4A, operable, that is total laryngectomy. And T4B, if it is inoperable, you can go for palliative. Okay. So this is and neck, if the lymph nodes are involved. So in case of lymph nodes, so what you have to do is neck dissection. So if you are operating for, in this case, if you are operating for any total laryngectomy or transoral laser microsurgery, whatever. Okay, so in if there is lymph node enlargement, simultaneously you should go for surgical excision. So that is neck dissection. How you excise the node by neck dissection. Okay, so neck dissection, it includes radical and modified radical. So if the primary tumor you are treating it by RT, then the neck should also be treated by RT, radiotherapy. If the primary you are going for surgery, the primary tumor you are going for surgery, the neck should also be surgery. That is your neck dissection. Okay. So radical neck dissection, what you will do, you will remove the lymph nodes level 1 to 5, and you will remove 11th cranial nerve, internal jugular vein, and sternocleidomastoid muscle. Along with that, you will remove parotid, submandibular, and omohyoid. This is radical neck dissection. You will be removing all this. So you will remove lymph node level 1 to 5, spinal accessory nerve, internal jugular vein, sternocleidomastoid muscle, along with that parotid gland, submandibular gland, and omohyoid muscle. Next is your modified radical neck dissection. In this, you will remove lymph nodes 1 to 5, but you preserve. With the structures you preserve, it is classified into types 1, 2, and 3. Okay, in type 1, you preserve 11th nerve. In type 2, you preserve, since it is 2, you are preserving two structures, 11th nerve and internal jugular vein. In 3, you are preserving everything. 11th nerve, internal jugular vein, and sternocleidomastoid muscle. Okay, so this type 3, it is called functional neck dissection. Or functional because you are preserving nearly all the three important structures. So you are maintaining the function. Okay. So in CA supraglottis, where the lymph nodes are most commonly involved. So if in CA supraglottis, if there is no node, you should empirically remove level 1, level 2, and level 3 lymph nodes. Okay. Even if there is no node involved, you should remove the 2. So if you are going by surgery for the primary tumor, if you are going for radiotherapy, then no need. Okay. And for extensive tumor, there is total laryngectomy. So laryngectomy, there are different types. I think it will be more vast, and it is not that much important for you. So just know the name. Total, if there is recurrence, or in T4A or recurrence, you can go for total laryngectomy. Okay. So I think that concludes the CA larynx. So now we will go into tracheostomy. Is just a short topic. It won't take much time. What is tracheostomy? So usually you do in cases of malignancies also. So that's why I plan to come together. So just opening in anterior wall of trachea. That is tracheostomy. Okay. So you can see here the tracheostomy tube in the anterior wall of trachea. Okay. So this is the anatomy, thyroid cartilage. So this is the cricoid cartilage. So in between is the cricothyroid membrane, and this is the first ring, second ring, and third ring. So most common tracheostomy is we between the second and third tracheal ring. So that is the most common. We do insert tube in second or third tracheal ring. Okay. So this is in high tracheostomy. We do in first ring. It is not done. It is not done commonly. Only in early, if the tumor presents early, and we are planning for total laryngectomy in future, we can go for high tracheostomy. Okay, so it is not recommended because there is high chances of tracheal stenosis. Okay, so the common indications for tracheostomy. So an obstruction in the airway. So the obstruction in the airway can be infective, any infections like epiglottitis, uh, uh, laryngitis. The obstruction can be tumor, so any malignancies. So far, we saw CL larynx or hypopharynx. In bilateral vocal cord palsy, in trauma, maxillofacial trauma, and in any foreign body. So in these obstructs the airway, infection. Okay, so obstruction. Next is prolonged mechanical ventilation. So this is the most common indication for elective tracheostomy. Okay, why? Because in mechanical ventilation, you can see the ET tube that has a cuff, which is in when the pressure is in, when we cuff the using the pressure, it rests around the cricoid cartilage. So since cricoid is around one single cartilage, there is more common chance for tracheal stenosis. So prolonged use of mechanical ventilation. Okay, when the cuff can cause tracheal stenosis, so we are going for elective tracheostomy, and also in prolonged mechanical ventilation, there is more chances of tubal block. ET tube can block frequently. Okay, so that can cause respiratory obstruction. So there is also another cause for tracheostomy. And next is any surgeries, any maxillofacial or head and neck surgeries. And to prevent aspiration. Okay, so these are the common indications you should know. So obstruction that includes infection or vocal cord palsies, foreign bodies, and prolonged mechanical ventilation, head and neck surgeries, and to prevent aspiration. Okay, so coming to the procedure. So this is the rose position. This position is also where we use for tonsillectomy surgeries. In rose position, there is extensional. So you can see this is atlanto-occipital and cervicothoracic joint. So there is extension at atlanto-occipital and extension at cervicothoracic joint. Okay. So we put the patient in this position. So that can give easy access during the surgeries. Okay. Next is incision. So commonly use vertical and horizontal incision. So vertical incision in emergency procedures, where you put the incision. So below cricoid to above the suprasternal notch. In elective surgeries, you go for horizontal incision. That is also called as skin crease incision. It is cosmetically better. Horizontal incision 2.5 centimeter above suprasternal notch. So this we do in elective tracheostomy. So after incision, what we do is we retract the strap muscles. Then we retract. After retracting the strap muscles, we will see thyroid gland. So we the isthmus of the thyroid gland. So we retract or pull up the thyroid gland using a thyroid hook. Okay, and then incision on the tracheal ring. So here you can see the strap muscles separated. Here in this they have just separated the thyroid gland, but usually we hook up the thyroid gland. Okay, so how you identify, confirm it is tracheal ring. So inside trachea there is here, so you can aspirate with the syringe for air. Okay, so this is the second, third, and fourth tracheal ring. So in you can incise in any of these rings. Okay, so you can see the tracheostomy tube getting inserted. So in the trachea, you can go for in this trachea also you can go for vertical or horizontal incision. Okay, depending upon whether it is elective or emergency whatsoever. So in emergency, we go for vertical incision, same as we saw in the skin incision. So this is incision on the trachea. Okay, so then we are inserting this is the plastic cupped tracheostomy tube. So this is the tracheostomy tube we are inserting. So this is the inflated cuff, inner cannula or inner tube. This is the outer tube. Here this is the circuit attachment for when the tube is connected to ventilator, a mechanical ventilation. So tracheostomy. So we are keeping the patient in rose position and steps your incision. If in a vertical, if in emergency you are going for vertical incision. In elective, we are going for horizontal incision. After incision, you will see the fascia. We are separating the layers. Retract the strap muscles, retract the thyroid gland, and incision on the tracheal ring, and then insert the tracheostomy tube. So this is the tube. So you can't keep the patient so far, depending on the patient whether he needs a permanent tracheostomy or a temporary tracheostomy. So if he needs a permanent tracheostomy, like CA larynx, so we are changing the tracheostomy to metal tracheostomy tube. Metal tracheostomy tube for it is helpful in speaking, because after the tracheostomy, once the tracheostomy is inserted, the patient cannot speak. Okay, why? Because it bypasses everything, so the patient cannot speak. But in metal tube, there is in this is Fuller's tube. There is, you can see some fenestra here, and there is some flanks. So you can ask the patient to close the opening and ask the patient to try to speak. It needs some speech therapy, but still the patient can able to speak. Okay, so this is Jackson's tube. Here also there will be small. The Jackson tube is a longer tube. If the patient is obese and he needs a longer cannula, you can go for Jackson's tube. This is Fuller's metal tracheostomy tube. So this is life after tracheostomy. Once there is tracheostomy, because it bypasses the upper airway, there will be loss of smell. The patient cannot speak and unable to build up intrathoracic pressure, because the function of larynx is completely lost. Okay. So complications of tracheostomy: immediate, intermediate, and late complications. So immediate, as usual, during the surgery, there will be bleeding, that is hemorrhage. Hemorrhage due to injury to vessels, so mostly thyroid artery or innominate artery. Aspiration, apnea, and pneumothorax. Okay, and injury to esophagus. These are the common immediate complications during surgery. And intermediate complication, there will be tube obstruction, which is the most common complication. In that case, you have to change the tube immediately, remove and change. Subcutaneous emphysema, tracheoesophageal fistula. Late complications, infections, as you know, commonly infections. There will be granulations around the tracheostomy site, tracheocutaneous fistula, and difficult decannulation. Decannulation means removing the tracheostomy tube after it's hit. So in case of emergency tracheostomy in any poisoning or any medical condition, when you do emergency tracheostomy and after the patient gets better, you have to remove the tracheostomy tube. Okay, so if it is prolonged, there might be difficulty in decannulation. So these are the common late complications. So I think I have covered tracheostomy also. So up to this is enough for tracheostomy. So any doubt you can ask. Thank you for your patience.
If there are any doubts, please post it in the comment box. There are any doubts, sir. Thank you for such a wonderful session, and I'm happy to announce that we'll be having one more session of Dr. Vinothan sir in the upcoming days. Thank you all for listening. Thank you, sir.
Any feedback, please you can come up. It can help to improve in the upcoming classes. Okay. So I hope the class was useful. You can. Can you understand?
Yes, sir. Yes, sir. Yes, sir. Please, sir.
Okay.
The review Mari post panni, I will send back it to you, sir.
Okay. Sure.
Okay, sir.
Okay.
Thank you so much.